Okay, so this will be your lecture on endocrine medications from chapter 40 in your ATI textbook. The objectives are going to fall along the same lines. So we're going to look at the mechanism of action, therapeutic use, side effects, patient teaching, nursing considerations, complications, and applying the nursing process to each one of these medications. So first set of medicines are going to deal with thyroid. And then we'll move on to other kind of hormone replacement or issues with the endocrine system. So the first type is going to be levothyroxine. So this is a synthetic thyroid hormone replacement for clients with hypothyroidism. So they don't have enough of the thyroid hormone. So this is a synthetic version of the thyroid hormone to replace what they're not getting. We also can use this in emergency treatment of myxedema coma, which we'll learn more about when we talk about hypothermia, hypothyroidism, not thermia, sorry. And we use it to maintain the hormone levels after surgery or radiation to the thyroid gland. That way levels are being not dropped dramatically. So we may give someone some hormone levels after surgery because they can be a little erratic. We'll talk about that a little bit more in a few slides with different medications. My nose is very itchy. So complications of levothyroxine. So this, some of you may know as Synthroid. So complications are going to be over medication. So if they get too much of this medication, then they're going to have symptoms of hyperthyroidism because that's what this hormone is. So if they get too much, then you're going to see all these symptoms of hyperthyroidism. So we need to monitor for those symptoms, which are listed in your textbook, and chronic overtreatment. So if they're used to taking the same amount of medication, they might actually still be slightly hyper, but not know it. So these mild symptoms, again, need to be even reported. In the event that the patient is taking catecholamines, these can increase their risk of dysrhythmias, which is an issue with hyperthyroidism. So it's even more so if they're taking catecholamines. Binding agents can reduce the absorption of levothyroxine, so they're not going to get as much of effect, so they may end up not getting therapeutic. If they're taking any kind of binding agent like sucralfate, which binds to the walls, we've talked about in the GI lecture. Also, anti-seizure and antidepressants can increase the metabolism of this medication, so actually they're not getting enough. That it's being taken up more quickly, and so it's too high for a short period of time, but then it runs out, and so then you're low. So you gotta get both effects. And then anticoagulants, taking an anticoagulant with levothyroxine, the anticoagulant effects can be increased. So then you're going to be looking for signs and symptoms of bleeding. So nursing considerations, we're going to, of course, obtain baseline vitals because thyroid hormone definitely affects most systems. I think of hyperthyroid as stimulation of all body systems, and hypo is delaying all body systems. So with hyperthermia, which we'll get in these lectures later, but maybe to help you understand it. So hyperthermia, which is what we're monitoring for as an adverse effect for this medication because it's thyroid hormone. You're looking at excitability of cardiac, so dysrhythmias, high blood pressure, excitability for neuro, insomnia, things like that. So overexcitability. So of course we need to obtain their baseline vitals so that we know if there's a change or increase in event vitals throughout their treatment. And height and weight as well. Sometimes this medication, if they're taking it as a young adult and they get older, of course their body mass increases, so their height and weight can, of course, change their dose. So we also need to monitor for any cardiac symptoms and their thyroid stimulating hormone and T4 levels. the thyroid for levels, it's the blood level. This is going to monitor for effectiveness. We want those, of course, to be increased because this is treating hypo. So that is where you're going to look at with a lot of these is what you're exactly treating, because they're going to be opposite. Education, so these are going to be administered in a low dose and then slowly increased over 6 to 8 weeks. They should take this on an empty stomach and don't discontinue it suddenly. The effectiveness we're going to see by a decreased level of their thyroid stimulating hormone at approximately the 6 to 8 week mark after therapy has started. The T4 levels should be in normal ranges, and they should be absent of any of those hypothyroid symptoms, because that's what we were treating. So hypothyroid symptoms would be like the constipation, the slowing of everything, all their symptoms. Your textbook talks about other symptoms as well, but think of everything as slowing. Now, thionamides are methimazole and propylthyrosol, PTU. These block thyroid hormone for treatment of Graves' disease. We can give it prior to a thyroidectomy or radiation, and emergency treatment of thyroid toxicosis, which was one of the complications of the previous medicine for treating hypo with the hormone, which led to hyperthyroid complications. So a hyperthyroid complication is thyroid toxicosis. So we have to be careful because it's blocking the hormone from being used, but it's still there. It doesn't get rid of the hormone. So it's still just kind of sitting out there. It's just not turned into a thyroid hormone yet. So it blocks it from that last step of process before it actually becomes thyroid hormone. We need to monitor these complications for hypothyroidism, because the purpose of this is to treat hyper. So our goal now is to decrease it, but if we decrease it too much, you can end up with hypo. Agranulocytosis, so we're going to look for infection, signs of infection. Their white blood cells are going to drop, monitor things like that. And liver injury and hepatitis with these medicines. These can injure your liver. Now, clients that are taking anticoagulants, again, their effects are increased, so looking for those signs and symptoms of bleeding. Also, digoxin levels can increase, so we need to monitor digoxin levels if they are taking digoxin at the same time as, say, PTU. Okay. Nursing considerations, we need to monitor their vital signs again, height and weight again, but this time we're also going to include their INO. Intake and output throughout the treatment. We're going to monitor the thyroid hormones, of course, but then we're adding here their CBC levels because of the agranulocytosis, okay? And of course, monitoring for those hypothyroid symptoms. We need to handle methimazole with care for any healthcare workers that are of childbearing age, as it can be radioactive and cause issues with us, so make sure you're using proper PPE when you are administering this to clients. Education, methimazole is usually the first line of therapy. We'll go to PTU if necessary. They may also need to take propranolol, because propranolol, being a beta blocker, can also decrease some of their symptoms of hyper, because remember, everything is stimulated. So if we can calm it down, they can kind of manage their symptoms a little bit better with propranolol in conjunction with this medication. So that's something that you might see together. They, of course, need to report signs and symptoms of infection for that issue of agranulocytosis. They need to be taking this at the same time of the day, just like with the other one, and don't discontinue it abruptly. But with these ones, they need to avoid shellfish and iodine products, because that's going to increase their hormone levels, and we don't want to increase, we want to decrease. And that's just how the thyroid works, is using iodine to get there, okay? Effectiveness may take 1 to 2 weeks initially, but full therapeutic effect can take up to 3 to 12 weeks. So that's really when we're going to start noticing the symptoms. So it's not, of course, going to be immediate. Okay. Now, radiopharmaceuticals, this is radioactive iodine. This destroys the thyroid hormone, whereas the other one just prevented it from becoming thyroid hormone. This one actually destroys it. The thyroid hormone producing cells for the treatment of hyperthyroid, thyroid cancer, and thyroid function studies. We can give low doses and see the reuptake in the thyroid gland to see how the thyroid gland is functioning, and then they excrete it. So complications are going to include radiation sickness because this is radioactive, bone marrow suppression because of the radiation, and hypothyroidism because that's our goal is to bring it down, but we don't want it to go down too low. Any other antithyroid that they are taking during this time should be discontinued 1 week prior to, because it can be left in the system for so long and they cannot be taken together. So whether this is a short time thing for treatment of cancer or for a study, or whatever the purpose that they're taking this, usually isn't going to be terribly long term. But if they were on something else, they need to wait a week before starting this. So this is not a new prescription that they start taking tomorrow. Okay. Nursing considerations, you need to avoid their, as best as you can, use proper PPE equipment, and handle carefully the client and the secretions, because the radioactive quality is still present in their secretions in the client until that rate of decay. So depending on how much they were given and for what purpose determines that length of time. That's why it's not specified, but so the clients need to know that they need to stay 6 feet away from each other. They shouldn't prepare food or share utensils with anyone else because they are radioactive. They need to limit contact to each person to only 30 minutes a day. So it's kind of like self-isolating, and increase their fluid intake to 2 to 3 liters per day to try and flush out that radioactive iodine, okay? And dispose of their body wastes. So that's going to include saliva, stool, emesis, and secretions, like mucus, secretions, when they blow their nose from a tissue. All of that shouldn't be just hanging around, especially not right now with COVID, but in general, they need to take care of their secretions themselves. Or in the hospital setting, that needs to be in a biohazard bag because those are radioactive. So then the effectiveness of this is that, of course, that they decrease their hyperthyroid symptoms, or they just have it for that short time of for the study, and the study is, of course, shows them what they want to know. All right. Okay. The next one we're going to talk about are iodine products. So usually I see or heard of legal solution. Your book also mentions sodium iodide and potassium iodide. The purpose of these are to reduce the uptake and block the release of thyroid hormone. Treatment prior to a thyroidectomy. So their goal is to have normal thyroid levels before they go into surgery, so it's not that dramatic drop again. So the euthyroid is the term that your book uses. So that's what it's doing, is trying to bring down the hyperthyroidism to a normal level before they take out the thyroid hormone. Or we can use it for the emergency treatment of thyroid toxicosis, again, that high thyroid level, and complications associated with it. So complications associated with iodine products are going to be iodism. So this is due to the corrosive property of it, and can progress to toxicity. So you need to be asking them questions about like a metallic taste, sore teeth, gums, like that. So paying attention to what your book mentions about symptoms of that, because it's the only real complication with this medication. Iodine high foods they need to be mindful of, because that's going to increase this effect, and therefore more than what we may want, because they have a prescribed dose for a reason. And then also hyperkalemia concerns, so other medications that may help produce a hyperkalemic state. So like potassium supplements, ACE inhibitors, lisinopril, things like that. So they may need to watch their potassium levels while they're doing this, if they're taking it at the same time. We need baseline vitals, weight, INO, again, throughout their treatment. This is usually an oral, the legal solution is a solution. So it's a oral solution, but it tastes horribly. So we will dilute this in juice to improve their taste. The clients need to know to increase their fluid intake to help flush out everything. Take at the same time every day, and no other iodine products as best as we can. And of course, don't discontinue abruptly. We're going to see the effectiveness, the therapeutic effect of this by evidence of weight gain, because with hyperthyroidism, everything's excited. So you're running through everything, your metabolism's up, so you're usually skinny. So that's why weight gain is actually a plus in this sense. Their vital signs are within normal limits. They have a decreased T3, T4 level, and their thyroid gland has shrunken, because usually in these cases it's large, and that's what they have a goiter, things like that, which we'll get into more when we talk about thyroid issues. And then of course free from complications of hyperthyroidism, which is what we're trying to bring down their levels with this, so we would hope that they would have no more symptoms of hyperthyroid. All right, now moving on from thyroid issues, now we are on anterior pituitary hormone and growth hormones. So the main one I want us to focus on is somatropin. The purpose is to stimulate production of protein and decrease the use of glucose for treatment of hormone deficiencies, AIDS wasting syndrome, and pediatric growth failure. Okay, so AIDS wasting syndrome are going to be clients that have AIDS. They get to a certain point that literally their body starts wasting away. So they need the protein to keep their weight, and they need to decrease their use of glucose so that they can use it for other means. And pediatric growth failure. So pediatric clients who have chronic kidney disease, cachexia, or short bowel syndrome, they may also have this issue. And so this helps with those two issues. Not necessarily that there's, this is for treatment of hormone deficiencies, but these other two issues can benefit from this despite having normal levels. So this isn't just because of abnormal levels of the hormone. Anyways, complications are going to be, of course, hyperglycemia, because we are decreasing the use of it, so it kind of sits around, and therefore the levels increase in their system. So we're going to look for hyperglycemia. We're going to look for inactivation. So if these hormones are being used and they don't really need the hormones, we're using it for the other effects, then your body's like, oh, I have too much, I'm not going to use it. I'll wait. That's what it does with like fat. It just holds on to it. So it'll just hold on to it. So then it's not actually getting what you need from that hormone. Growth factor, of course, you need. So then you get inactivation, and you get stunted growth and things like that. And then hypercalciuria, so high calcium in the urine. And in those cases, that can lead to kidney stones, renal calculi. So the calcium deposits all form up and become a kidney stone. So that is another complication of this medication, somatropin. Clients that are also taking glucocorticoids may counteract the effects of this medication because glucocorticoids may increase the glucose that we'll see again in a moment. And so if we're already increasing the hyperglycemia, then your body's like, oh, I don't know what to do with this. So then it counteracts the effects of this and gets rid of the glucose by trying to pee it out and everything because the levels are so high. And so we'll actually reduce the effects of what we want, which is we want the glucose to stay. Okay, nursing considerations, again, baseline height, weight, but we're going to add growth patterns to this. We're going to monitor their growth patterns monthly because this deals with the growth hormone. Education is to reconstitute this. You have to mix it gently, don't shake it, and don't administer if particulates or any discoloration occurs during that process. Sorry, my chair is very squeaky. So particulates are the little particles or crystals that happen in the process of mixing it, or any discoloration, it should be clear. And again, mixing it gently like we do with the insulins, we roll it, you're not shaking it, okay? And then they need to rotate their sites, of course, to decrease infection and increase absorption of it. So they can rotate in their abdomen and they can rotate in their thighs. Effectiveness is going to be hopefully seeing an increase in their height and weight because this is a growth hormone. So that is the purpose that we're doing it. Okay. All right. Antidiuretic hormone, so such as vasopressin and desmopressin. The purpose of these are going to be to promote reabsorption of water in the kidney through vasoconstriction. So if we vasoconstrict and hold all that water in there, we're going to reabsorb that water. For treatment of diabetes insipidus, so that is a complication with that they are diabetes insipidus. Just a little tidbit, they tend to pee out a lot. So that is the issue with them, is that they may be easily dehydrated. They feel very thirsty, so they drink, but then they pee. They don't actually keep everything. So this is going to help those kind of clients retain some of that water instead of kicking out every ounce of water that they get in. We can also use this, which was interesting to me, during CPR, because it will decrease the blood flow to the periphery and save it for like your brain and your cardiac. So it's kind of inducing that fight or flight thing where everything, which it should be already kind of doing that, because your body is definitely in shock during CPR because your heart has stopped, but this can help in some of those situations that they've seen apparently. Also, we see these medicines for nocturnal enuresis. So this is bedwetting in the middle of the night, as well as for hemophilia. So usually for nocturnal urination, it'll be like an intranasal spray. So we'll get to that in a moment. Complications are going to be water intoxication, because if we keep all that water, then everything is so diluted, all of your electrolytes are going to be become an issue. So we do need to monitor for that fluid intoxication by retaining that water. Also, myocardial infarction, because again, all those electrolytes are going to be abnormal by retaining all that water. So we need to monitor those electrolytes, especially potassium, as that can cause dysrhythmias and can lead to heart attack, which is what a myocardial infarction is. Myocardial ischemia. Sorry, is what your book said, but ischemia leads to infarction. Tricyclic antidepressants, if they're taking a tricyclic antidepressant, this can increase the effects of this medication, whereas alcohol, heparin, and lithium and phenytoin can decrease the effects of this medicine. So we need to monitor those and adjust if necessary. Considerations, we're going to, of course, monitor the vital signs. Their CVP, so this is their coronary. Why am I blanking on CVP? Central venous pressure. I don't know why I wanted to say cardio, because I was just talking about cardio. anyways, I hope you got a laugh out of that. So central venous pressure. So if we're retaining all that fluid, then the venous pressure, of course, is going to be elevated. So need to monitor for that. We're going to watch their eye and nose, of course. Specific gravity, because that's going to show us if it's the diabetes insipidus is getting better or not, because their specific gravity in their urine, of course, is going to be more dilute because they're ping all that water out. So we hope that the specific gravity will return back to normal ranges. Potassium levels, sodium levels, BUN, creatinine, and osmolality, of course, as we're retaining all that water. So we also need to monitor daily weights and monitor for water intoxication. So these are going to be your headache, drowsiness, confusions symptoms, okay? Intranasal desmopressin, like I said, can be used for that nocturnal urination. So we're going to use it at bedtime. So it's most effective when you need it. They'll start it with once at bedtime, and then once they have achieved effectiveness of it, they might increase it to twice to continue the effect, so that your body doesn't get, because your body will get used to it. Education, we're going to restrict water intake, of course, because we want them to retain what's in there. Diabetes insipidus, like I said, they're going to be wanting to drink so they can pee, but we want them to keep the water that's in there. And so it's a weird process. So they need to restrict their diet and their water intake and stop if toxicity is suspected. So if that water intoxication is suspected, then of course they have too much water, so they need to stop drinking. But their brain is telling them that they need to drink. So that's going to be important education for these type of clients. All right, so effectiveness, we're going to hope to see a reduced urine output, so they're not peeing all the time, for patients that have diabetes insipidus. So we're goal then is going to be 1.5 to 2 liters a day that they're urinating, because they can pee 4 or 5 liters in a day, which leads to the dehydration issue. So this is all trying to correct the dehydration issue and help them not be so dehydrated, retaining that water. So all of our complications and issues that we want to monitor for is for too much water. And then, of course, the other reason of giving this was during CPR. So then hopefully they survive cardiac arrest if it was given for that reason. Okay, adrenal hormone. This is going to be hydrocortisone, and then your glucocorticoids, which are prednisone and dexamethasone. The purpose are going to be to mimic natural steroid hormones for the treatment of adrenocortical insufficiency, cancer, inflammation, or allergic reactions. We've talked about glucocorticoids for inflammation and allergies before, but now we're going to talk about it in the sense of adrenocortical insufficiency. So complications of this are going to be, of course, glucose intolerance, like with the glucocorticoids. So we're going to look for, monitor their glucose levels. Fluid and electrolyte changes can occur, so we're going to monitor their electrolytes. Osteoporosis, again with glucocorticoids. A lot of these first section all the way till the semicolon are all because specific to glucocorticoid classification. Adrenal suppression, peptic ulcers, GI discomfort, infection, and Cushing syndrome. So those are all from the glucocorticoids. And then retention of sodium and water is going to be a complication of the hydrocortisone. Okay. Patients with diabetes mellitus, that's what DM stands for, need to, of course, then monitor their glucose levels and may need to adjust their medications accordingly. We'll also need to watch for hypokalemia and with other medications that, like potassium, non-potassium sparing diuretics and things like that, that we're looking for issues of low potassium levels. Whereas another medication that we talked about just a few slides ago was about medications with hyper K. So remember the differences there again. Considerations, we're going to monitor the weight, vital signs, electrolytes, and glucose, like I said. We're going to give with food to reduce that GI distress if possible. Education, of course, don't stop abruptly. They should taper this off if they are to discontinue it. We need to educate them on signs and symptoms of peptic ulcer manifestation, so like the coffee ground emesis, signs and symptoms of bleeding, things like that, and as well as signs and symptoms of adrenal insufficiency. May need to increase their dose during stressful times, so like trauma or surgery or just stress may affect the levels that they may need in order to effectively treat it. So we talked about before with like glucocorticoids treating musculoskeletal disorders, and so they may have an exacerbation during stress, and so then they needed that extra dose. Remember, so this is the same thing. So glucocorticoids aren't as effective or the body doesn't use it effectively during times of stress, so they may need more levels for the body to use it correctly. They need to carry extra doses for emergencies and wear an ID bracelet. And then effectiveness, we should see a relief in adrenal corticoid deficiency effects. So of course you need to know the adrenal corticoid deficiency effects, which are listed in your book, to know that this is effective. Hyperpituitarism medications. The one I want you to focus on is octreotide. Octreotide. I wanted to say ostrich for some reason. I'm sorry. Anyway, so the purpose is to suppress the growth hormone release in treatment for gigantism in children and acromegaly in adults. So this is the big people that have too much growth hormone. That's why we're suppressing the growth hormone. So complications are going to be GI disturbances and glucose irregularities. We need to monitor clients that are also taking antidiuretic medications, as it can cause issues and dysrhythmias. Also, if they're diabetic and taking insulin, we need to monitor their glucose levels because it may not be as effective, or it may be too much. It can go either way in this case. So we do need to be monitoring them very closely. So caution, like I say here, for the considerations in clients with diabetes, mellitus, hypothyroidism, renal disease, gallbladder disease, and older adults. Now, typically clients with an overproduction of growth hormone and have gotten to the point of gigantism or acromegaly, they usually have a lot of other organ issues or deficiencies and things like that. So this is going to be really tricky to find and be appropriate for clients. So this is not always an option, is what I'm getting at, because like you see, you have to be cautious in these types of patients, and that's common because of the process that's going on here. So it can be tricky to treat, and this is really the only one that we can use that I know of, and that your book talks about. So education is going to be on how to administer it subcutaneously, so using it at the 45-degree angle, rotating sites in their abdomen, their hip, and their thigh. So these ones they can rotate to their hip, whereas the other one was only the abdomen and thigh. Remember the differences. They can also administer IM, so education on how to give it IM, but they should only deliver it IM to the thigh. They should not give it to their deltoid. They should administer it slowly after reconstitution, and it reaches room temperature. Okay. Usually we can resort to this when surgery and radiation are not effective or not an option, and in those cases that those don't exist, of those deficiencies. Effectiveness of effectiveness is, of course, going to be then the suppression of growth hormone for management of those disease process. So that is what we're using it for. So then, of course, we would like to see less growth hormone in the body. All right, so this concludes your endocrine medications lecture. These were on pages 319 to 326 in your ATI textbook. I will open up a discussion thread for Module 4 shortly, and that way you can review any questions there with me throughout the next following weeks. Thank you. Bye.